Leigh's been with the study for about 12 years, and her special interest is in women's health, and in particular, the health impacts and determinants of health in women carers. So I'll hand over to Leigh to get started. Thank you, Leigh.
Okay, thank you very much. Thank you, everybody, for joining us. Today, I'd like to launch this report, which was prepared for the Australian Government Department of Health. The provision of informal or unpaid care to another person is an important and often significant part of women's lives. And for many women, these roles and responsibilities occur at multiple points along their life course, usually driven by relationships between and within generations. Women care for grandchildren, they care for their children, they care for parents, other family members, friends, and then often as they age, they care for their spouses, partners. And they often transition in and out of caregiving roles as well, while managing other responsibilities, for example, employment and other aspects of family life. So what we wanted to do in this report was to have a look at the patterns of caregiving by Australian women across the life course, using data from women aged from 18 to 97 years. We wanted to look at some of the socio-demographic factors associated with caregiving patterns and the impact of caregiving on social, employment and other health outcomes of caregivers, including health service use. And we've been able to use both responses from survey data as well as free text comments written by the women to inform our findings in this report. So what I'd like to do is give a brief overview of the Australian Longitudinal Study on Women's Health so you understand the context from which the data come. And then I'd like to provide a snapshot of some of the major findings from the report covering 4 specific areas, and one being use of formal and informal childcare, caring for grandchildren, caring for the long-term ill, disabled or frail, and the experience of dual or what's often called sandwich caregiving. And we included childcare, use of formal and informal childcare in this report, because often when data come out about the impact of informal caregiving, childcare isn't included. Often the focus is more on people who are elderly or frail or disabled. But obviously women spend an awful lot of their time doing childcare, as not only when their children are younger, but as they're older and also when they become grandparents. So we wanted to include this to have a broader definition and a broader scope of the impact it has on women's lives. So to begin with, for those of you who aren't aware of the Australian Longitudinal Study on Women's Health, it's a study of over 57,000 women from across Australia. And as the slide shows, we have women from 4 cohorts. We have a group of women, over 17,000, who were born between 1989 and 95. We have over 14,200 women who were born between 1973 and 78. We have women born between 1946 to 51. We have over 13,700 of these women. And finally, we have our oldest cohort, and these are women born between 1921 and 26, who, when the study started, were 70 to 75 and now in their 90s. And when the study started, we had over 12,400 of these women. So the study's been going for 22 years, and it's been continuously funded ever since that time. So when the study began, we oversampled women living in rural and remote areas so that we would have continued representation of the health and the factors that affect the health of women from these areas as the study progressed, and we still have very good representation. The map of Australia shows a dot for all the participants in the study, and as you can see, the study is generally quite representative of women across Australia. The study is essentially a national research resource. It's been funded continuously since 1996 by the Australian Government Department of Health. And the whole idea of the study is to assess all the aspects of a woman's health and well-being to help inform the development of policy and practice. So we look at just about every aspect of women's health that you can think of, ranging from their physical health, their health service use, their emotional health, socio-demographic factors associated with health, key life events or life stages, how women spend their time, including things like caregiving. We're very fortunate to be able to link our data to administrative data sets, including the MBS and the PBS, to state hospital perinatal cancer data sets, aged care data sets, and some emergency department data sets. So the data are available for free upon request. You apply for the data and it goes through a committee. And since 1996, we've had over 1,200 collaborators use our data. We've currently got over 600 people using the data. And you can imagine such a rich source of data has resulted in over 700 peer-reviewed papers and lots of chapters, book chapters, and we've had, for example, over 60 PhD students use their data. So it's a wealth of data with data on over 57,000 women. So how do we ask about caregiving in the study? So these are essentially the questions that we have asked. The women get surveys roughly every 3 years. The oldest cohort has been surveyed every 6 months for the past few years, and the very youngest cohort, we do yearly surveys with them at the moment. But generally, we've asked women questions like whether they provided care to a child, a grandchild, or another person's child. We've asked women whether they provide unpaid care to somebody because of their long-term illness, disability, or frailty. We ask what's their relationship to the person they care for, where do they live in relation to that person, and we ask questions about the intensity of caregiving that they provide. We ask women about their use of childcare, both formal and informal, and we also ask them about their perceptions of how convenient it is, the availability of it, and the costs of it. We ask women about their perceptions of the satisfaction with the childcare arrangements that they have. For women who are caring for an adult, we ask them how happy they are with their share of caring for that particular person. And every survey has an opportunity for the women to write free text comments, and so we get a wealth of qualitative data as well, some of which I will be presenting to you today. Okay, so turning to the first area that I'd like to talk about, and that is a snapshot of some of our data on informal and formal childcare. So this slide shows data from women in our 73 to 78 cohort, from survey 4 when they were aged 28 to 33, across to survey 7 when they were aged 37 to 42. And as you can see is that at survey 4, when the women were aged 28 to 33, about 75% of them reported using childcare. About 21% had only formal childcare, about 28% used informal only, and just over a quarter used both types of childcare. So as the women have aged and as their children have aged, this percentage has dropped. However, at the age of 37 to 42, still over 60% of women in this age group are using some form of childcare. So in the report, we talk about some of the socio-demographic factors that are associated with the use of childcare in women in this 73 to 78 cohort. These data mostly come from survey 7 when the women were aged 37 to 42. So basically what we found is that childcare use, particularly informal childcare, was highest in women who were working, either part-time or full-time, and those with higher levels of education. Women who were working full-time used more hours of both types, but used more informal than formal. In regards to how well women reported being able to manage on their available income, we found that women who reported less income stress, so said that it was fairly easy to manage on their available income, were more likely to use up to 20 hours a week of childcare. But it was interesting that use of more than 20 hours a week of formal and informal care was actually similar, regardless of how well women reported managing on their income. So women who reported that it was very difficult or impossible were just as likely to use more than 20 hours a week of formal or informal childcare than women who said it was very easy to manage on their available income. So this may reflect the necessity in these women's lives of having to use childcare, and the fact that even if they're struggling on their income, they still are using quite large hours of care. We found that women in major cities used more formal childcare services than women who lived in outer regional, inner regional or remote areas, and that women who were living in the remotest areas were less likely to use informal childcare. When we asked the women about their perceptions of formal childcare and if they used formal childcare, whether they had informal care available, this was what they said. So what we found is that overwhelmingly, sort of around the high 90 to sort of low 90s to high 90%, women overwhelmingly found childcare to be at a convenient location and to be available. We found that about 30% of the women in this cohort found the cost of childcare to be a problem. And of the women who used formal childcare, about 60% said that they also had informal childcare available. We had a look at some of the associations between socio-demographic factors on these perceptions, and generally we found that higher socio-demographic status in the women, or women of a higher socioeconomic status, were more likely to perceive that formal childcare was more conveniently located and was more affordable. And it was interesting that in terms of perception of availability and location, a similar proportion of women living in inner and outer regional areas reported that places were available and that locations were convenient as the women in the major cities did. The difference came through with women living in remote and very remote areas, where about 10% fewer women who lived there said that it was convenient or available. But it was still around 80% who said that it was. In terms of perception of cost, interestingly enough, fewer women living in remote areas perceive the cost of childcare to be a problem compared with people living in major cities. We also had another question that's not on this slide about how satisfied women were with their childcare arrangements. And overwhelmingly, about 90% of women said that they were. So in terms of finishing the snapshot section on childcare, I'd just like to finish with some of the quotes from the women. A lot of the women write quite extensive qualitative comments on the back of the survey, and we were able to analyse these within a context of caring for children and how women juggle this with working outside the home. And so just to give you an example of some of the quotes, having 3 children, I feel constantly exhausted and overwhelmed on a daily basis, juggling work, family, friends, relationships with husband and house duties. But I still love my life. Most women my age that I speak to say they feel the same. Another comment, I had to give up my senior management role to put my family first, and now I can't get a look in for anything because I can't work full time. It seems I can be a mum or a professional, but not both. Why are women still cornered into this type of decision? And another example of a quote, having had a child in the last year and needing childcare, I have found it to be quite expensive. Although the government is subsidising it, I found that the money I get for working doesn't actually cover it. And actually working means I get less subsidy, which means it covers even less. The system seems designed to keep mothers in the home. And there were many, many more comments, and the report details quite a few more. But overwhelmingly, this analysis of the comments suggests that certainly being a mother is difficult and challenging, and the women talk about having to juggle multiple roles. And that while they shared their own individual experiences, the exhaustion from managing the demands of it all was a common theme. They talked about returning to paid work and how it was often a compromise, either in the type of job, hours worked, money earned, or for some deciding not to return. Those who decided not to return sometimes spoke about concern for their job prospects in the future, and others had difficulty adjusting to not being in paid employment anymore. The issue of flexibility offered by some workplaces was mentioned by some women. Some women talked about finding work with flexible hours and how perfect it was, and others talked about, like the example of the quote here, being unable to work part-time in their chosen career. And certainly flexible working conditions facilitated a return to paid work. The women talked about using various combinations of childcare, informal care, formal care. A lot of women praised their mothers and the support they got from their mothers. The cost and availability of childcare was a concern for some, while for others the cost was prohibitive and was the reason that they didn't go back to paid employment. And overwhelmingly though, although there were a lot of the struggles and the difficulties that these women were experiencing in their comments, many also reflected positively on their life circumstances in terms of loving being a mother. Now, in terms of childcare, we also looked at childcare by older women because we know that there's a lot of care that happens by grandparents. And so we asked questions in the women in the 1946 to 51 and the 1921 to 26 cohorts about whether they provided childcare and how satisfied they were with it. And with women in the 1946 to 51 cohort, we found that at ages 47 to 52, about 41% of them were providing this type of childcare, and that rose to 60% when women were aged 65 to 70, with 20% of them doing it daily or weekly. And women who were working part-time or who weren't working were equally likely to provide childcare as opposed to women who were working full-time. But we were interested to see that 23% of those who were working full-time were still providing care for their grandchildren. And over 90% of them were happy with their share of providing this type of care. In terms of our oldest cohort, 45% of women aged 73 to 78 were providing care. And we were amazed that 12% of women aged 85 to 90 were still providing care for a grandchild. And certainly those who were providing this type of childcare reported better self-reported health. And in these women's comments, that the older women certainly talked about the joy that they get from caring for their grandchildren. Okay, so the next snapshot I want to give you from the report is moving to caring for somebody due to frailty, disability or old age. So with this question, this slide shows the overall prevalence at various ages of our women across the life course. The top line shows women who were living elsewhere to the person they cared for, and the bottom line of the graph is the women who were living with the person they cared for. So you can see that, and these statistics are no surprise, that this type of caregiving is most prevalent in middle age, and this percentages with our women peaked at around ages 56 to 64 at about 30%, that's total care. And as the women aged, the percent who reported living in care increased slightly, while the live elsewhere care decreased. When women hit their sort of early 80s, the percentage who were caring dramatically dropped off, probably due to widowhood or moving into residential care. We looked at some of the factors associated with who's providing this type of care, and we found that for middle-aged caregivers who were living with the person they cared for were more likely to not be in the labour force, to have less levels of education and to be struggling more to manage on their income. However, we didn't find any differences by where these women lived in terms of the area of residence. So looking at the other cohorts, the prevalence of caregiving for somebody due to frailty, disability or old age is much less in our youngest women, hovering around 5 to 6%. It's starting to increase. At the last time that we met these women, they were up to age 42. It'll be interesting to see how this prevalence has increased at our next survey. And similarly to the women of the older cohort, of the 46-51 cohort, these women who were providing this living care generally had poorer socioeconomic status. In terms of caregiving in the 21 to 26 cohort, there was no difference in socioeconomic status between who did or did not provide care. So this next slide is a summary that shows the transitional nature of caring for somebody due to frailty, disability or old age. So if you look at the slide, the dark purple are the responses at each survey of women who say yes, they're providing this type of care, and the light purple is those who are saying no. Now, this slide represents the survey data from 6,598 women who were born between 1946 to 51, who answered each of surveys 3, 4, 5, 6, 7, and 8. So we have complete caregiving data on them across all of those surveys. So we're able to work out the transitions in caring. And as you can see, that of those who were caring at survey 3, that by the time survey 4 came around, a few of them had stopped caring, while a new group had started caring. And this pattern follows on through all of the surveys. And in fact, the slide shows that across all of these surveys, only about 4% of women reported providing this type of care at every survey. And 36% provided no care of this type at any survey. So it really is a very transitional activity that women are doing. We had a look at some of the associations of live-in caregiving with health and health service use in the 1946 to 51 cohort. And basically, we found that these women had poorer self-reported health. They're more likely to be less active, to smoke and to be obese. They had poor adherence to guidelines for fruit intake. They were less likely to adhere to PAP test recommendations, more likely to report 3 or more chronic conditions, to report high levels of stress, anxiety and depression, and to have higher health service use in terms of GP visits and prescriptions filled. So we're really seeing that those associations with that, the most, I guess, intense care you can do, which is that live-in caring in middle age and these health outcomes. We also looked at this in the 73-78 cohort, and we found some similar results in terms of poorer health and health-related behaviours and greater use of health services. However, there wasn't the difference in the health behaviours as such. We also looked at this in the 1921 to 26 cohort. And so again, these are the women who are providing the live-in caring. And we're finding that the live-in caring of the older women had poorer self-rated health. They had poorer health. The live elsewhere caregivers had the better health. But there was no differences in some of the other health outcomes such as anxiety and depression or health service use. Okay, so another snapshot to show you is some of the questions we've asked about intensity of care. So with these questions, we asked about how often they provide care and for how long they provide care. And so an example of a low intensity caregiving is, for example, caregiving once a week for an hour at a time, or caregiving every few weeks for several hours. Example of a medium intensity caregiving would be caregiving several times per week for several hours, or caregiving every day for about an hour. And then the highest intensity caregiving was when women were caring all day or all night, several times a week, or every day for several hours at a time. And so this slide, I've tried to summarise some of the results of some of the associations, some of the factors that were associated with intensity of care. And again, this was in the group who does the most caregiving in our study, which is the 1946-51 cohort. And this is when they were 65 to 70. And so these women, the women who were providing the most intense care were the women who were living with the person they cared for, often a child or a spouse, and where the person had conditions such as heart disease, stroke, cancer, mental health problems, respiratory conditions. More medium intensity care was provided by these women for people who had conditions like visual impairment or Alzheimer's disease, dementia, and lower intensity care was provided by women who were more likely to live elsewhere to the person they cared for, such as a parent, a relative, friend, neighbour, and also when they were providing care for somebody who had frailty. So again, I'd just like to conclude this section by talking about some of the qualitative comments that these people wrote on their survey. And again, this is just a snapshot of some of them. The report has a lot more detail. So surveys, for example, all I can say is I'm a very sad lady because I've had to put my only love of 59 years into hospital. He's been there 2.5 years. I feel I have let him down. He can't understand why. The trouble is he can't even stand, so how can I give him the care he needs? I go and see him every day, but it doesn't make him feel better. Another comment, my husband was diagnosed with Alzheimer's last year and is in the early stage. At 90, he is very frail physically and no longer drives, shops or cooks. However, I am managing to care for him. Respite care 1 day a week and weekly help with heavy cleaning helps. My osteoarthritis has worsened, but so far I'm coping. And the last quote, my partner has dementia. It's been very difficult on my own, but now he is on a package and the help and support I am receiving is such a godsend and I don't feel isolated now. I get 6 hours me time and 5 hours cleaning assistance. So along with these comments, as I said, there were many others, and the key themes arising from this analysis included giving and receiving care, the fact that having support services really helps, and also informal support services from family and friends, her health, as in her own health issues or neglect of her own health, issues to do with housing, uncertainty, and how she feels, so the emotions that go along with all of these, as is typified by some of these comments. And sometimes providing this care was difficult and frustrating, particularly as the woman watched their partner's age and deteriorate over time. There was quite a lot of women who talked about having their own ill health and their own conditions and how it all sort of hits them at once. But then there was a common theme about needing to continue to provide care for their partner as long as it was needed, despite their own issues. And some women actively wrote about neglecting their own health to care for their husbands. And other quotes from the women expressed the desire to remain independent and in their own homes as long as possible, including once their partners had died, and being able to access the care they required, and really worrying about what's going to happen once they're widowed. And I guess some of the implications from this is ensuring that these women have sufficient personal and emotional care when they become widowed, which is essential to their ongoing health and ability to live independently. And also the importance of the formal and informal care that not only assists the women to care for their husbands, but also for themselves. And as most women reported that the person they cared for was their spouse, some caregiving burden for these women who were also in need of assistance often could be alleviated by a more coordinated approach in terms of services. And ideas for this could be a couples care plan rather than individual care plans provided by different services. So I'd like to turn now to another snapshot from the report, which was to do with dual or sandwich caregiving. So these data were generated by the questions asking women whether they care for more than one generation, whether they care for children as well as caring for somebody who is old, frail or disabled. And what we found was that of the 1973 to 78 cohort, when they were aged 37 to 42, about 11% of them provided this care. For the 1946 cohort, at ages 65 to 70, about a quarter of these women were providing this dual or multi-generational caregiving, and about 10% of our 21 to 26 cohort at the ages of 79 to 84 were providing this type of care. We found that with the two younger cohorts that the multi-generational or the dual caregiving was more prevalent by women who were living with the person they cared for. So they were living with the person they cared for who was frail, elderly or disabled. And as well as that, they were providing childcare to their grandchildren. So that was the most prevalent type of this type of caregiving that the women were providing. In the oldest cohort, women who were more likely to provide this type of dual caregiving were more likely to not be living with the person that they were caring for, but to be living elsewhere from them. So we did a lot of sort of trying to break down and analyse all the different combinations of dual caregiving. And this slide is just one example of some of one result that we found. And I'll just talk you through the slide. So on the x-axis, you've got the 6 different categories that we use. So the CC plus live-in is women who were providing childcare plus live-in care for somebody who was frail, disabled or elderly. The CC plus live-else is they were providing childcare plus caring for someone who lived elsewhere. Then there was childcare only. Then there was live-in for someone who was frail, disabled or elderly only. Then there was live elsewhere care for someone who was frail, elderly or disabled. And then there were the women who were providing no care. So this slide is an example of self-reported depression from women in the 1946 to 51 cohort, and that's at survey 8. So these women were 67 to 72 at this particular point in time. And it just shows the complexity between trying to get a grasp on the associations between dual caregiving and health. And there's a lot more detail in the report, and I have a summary slide coming next. But in this slide, you can see that women who provided childcare and lived in with somebody who was frail, elderly or disabled had about 18% of these women reported that they had depression, so self-reported depression. And as a group, they were actually similar, statistically similar to those who provided live-in care, but no childcare, live elsewhere care, or didn't care. It was women who provided childcare plus live elsewhere care or childcare only. The prevalence of self-reported depression was about 10% lower in this particular group. So on this slide, I've tried to summarise some of the associations that are provided in more detail in the report, just to try to give you a sense of the type of patterns that we're finding. And we've looked at things here like self-rated health, which is the SRH, physical activity, which is the PA, GP visits, stress, alcohol consumption, depression. And what we found here is that the findings generally differed by age, and you've got the 3 cohorts. You've got the oldest cohort in the top row, the middle cohort, the mid-age cohort in the middle row, and then the youngest cohort in the bottom row. And the findings generally differed by age, but overwhelmingly the dual caregiving, particularly the living caregiving, was associated with poorer health outcomes than other types of caregiving. So the type of caregiving that was related to the least amount of health, poor health outcomes, you could say, was the childcare. And often women who were providing childcare plus other types of care were doing pretty well compared to people who were just providing the live-in care for someone who was frail, disabled or older. So there's quite an interesting pattern of sort of information that you can break down from this kind of detailed information. So I'd like to finish with again a bit of a discussion about some of the comments that these women talked about in terms of finding themselves in a position of being a sandwich generation. So an example of this is, my situation is in flux. Since particular year, I have experienced one of my children being diagnosed twice with a savage childhood cancer, and then my husband with prostate cancer. So this affects all areas of your life, emotionally, physically, mentally, financially. Another quote, life for the past 8 years has been travelling weekly to my parents, 115 kilometres each way for 3 days, as well as school pickups of 6-year-old granddaughter, 50-kilometre round trip twice a week. Dad at 94 is still doing well at home, and the thought of driving each week for another 6 years is daunting. It's sucking me dry. And the final quote, however, between helping our daughter raise the 2 gorgeous girls, also supporting her through a dreadful divorce, together with the daily challenges of my mother with Alzheimer's, my supportive, beautiful husband and I have very little free time to enjoy our 60s. We didn't in our wildest dreams think we would be in this situation for our age, having worked so hard for 41 years. And there are a lot more comments in the report. But essentially, multi-generational caring, or being a sandwich caregiver, is often challenging and stressful. And although caring duties fluctuate, many women provided care for their families over many years. with some women reporting providing care for 3 generations, parents, children, grandchildren at the same time. And many women reported lacking time to focus on their own health and well-being, and it seemed there was a lack of support beyond the family unit to assist with this care. Certainly more accessible and affordable childcare options for parents returning to work may reduce the burden on grandparents of caring for their grandchildren. We think more research is needed to investigate the impact of long-term multi-generational caregiving among those who are reaching retirement age, and particularly when they're experiencing their own age-related health issues. And interesting, while childcare and respite care may be available to caregivers, these are rarely, if ever, offered as a coordinated support service. And so the complex support needs of caregivers in this position certainly warrants more individual assessment and attention. So I'd like to conclude there by saying that this report has generated a lot of information and detail about caregiving across the life course. There's a lot more detail in the actual report, and I hope that you will find the report useful and interesting. And I thank you very much for your attention and for listening. And I would like to invite any questions.
Okay, Leigh, I'll remind everyone the question button is down the bottom of the box, and I'll give you just a few seconds to have a think and type them in. I have to say, listening to all of those quotes from the women really resonated with me, and some of them are absolutely heartbreaking.
Yeah, so we've had one question come in, and I'll read it to you. It says, caregiving has negative health impact and is also based on physical ability to care. Given increased obesity rates and its impact on health, should we be concerned about a lack of able carers as the younger generations age? I thank you very much, Christine, for that question. Certainly, we know that obesity rates are increasing. Our own data are showing that very clearly, and the projections of the increase over time is also very concerning. Certainly, we know that with our younger women, they are experiencing chronic diseases earlier, likely due to issues such as obesity and other factors. However, we also know from our data that even though a lot of these women are carrying extra weight, their participation in other healthy behaviours, such as physical activity and not smoking, is actually quite high. And so we are hopeful that their health will remain as good as it can be due to these other positive factors. But certainly the comments that come through from the women is that they are struggling at times with caregiving, but they also love their life and they love doing it. So I think it's going to be something that I think women in particular will just continue to do. But I certainly agree there is probably going to be a lot more demand on other health services to step in, particularly if future generations do not have the lifespan that their parents have enjoyed.
Thank you, Leigh. And we do have another question, which is, why haven't we included results for the youngest generation in our survey on caregiving?
Yes, the 89 to 95 cohort. Okay, so these women were newly recruited into our study in 2013 when they were 18 to 23 years, and we know. So they are still in their 20s now. And we know from our 73 to 78 cohort, and you would have seen on the slide I put up, the percentages of women who are caregiving is very low at those ages, and it doesn't start to really increase until these women are in their 40s and older. So we didn't include the youngest cohort in this particular report because the numbers who are providing care was just too small.
Thank you, Leigh. We've had a few more come in, so we'll get through them as we go.
Okay, so we've had a question from Anita asking whether we have findings on the cultural backgrounds of these women. I can break those data down. We do have some information, Anita. I don't have that to hand. However, I might be able to get that for you. If you were able to email me, I could see what I could certainly see what I can find. We have information on the country that the women were born in, the language they speak, and if they were not born in Australia when they arrived. And I don't know, just trying to think whether we looked at that for this report. I don't think we did specifically, but I might be able to get an answer for you if you were to email me. Okay, just looking at other questions. So there's a question here about any questions about sharing caring roles with siblings. We didn't specifically ask that question. However, we did ask the women, are you happy with your share of caregiving? And one of the responses was, yes, I'm happy. No, I'm not happy. And I wish my other members of my family would do more. So we touch on that aspect with that question. And as I presented, overwhelmingly, the women who are caring say they're pretty satisfied with it. We do have a small percent, but it is probably less than 20% who say no, they wish other family members would do more. Okay, so I'm just looking at small questions as they come in. Interesting, have you considered number of children and its effect on childcare? We did. It's what we found in terms of effect on childcare. Again, I don't have that data to my fingertips. From memory, the women who had the most number of children were least likely to use a lot of childcare because they tended to not be working. We do know one very interesting finding that I can recall is that women, these are the younger women, the 73 to 78 cohort, who have 3 or more children, are also more likely out of any other woman in that cohort to provide live-in care for somebody with frailty, disability or old age. So that was one really interesting finding. Whether that's due to the fact that they are already, maybe they live in a bigger family and they're on hand to do the caring, I'm not sure. Let's just have a look at another question about for qualitative feedback. Do you have a combined list of health problems described by the women other than the usual selected chronic conditions? The women certainly write in their qualitative comments about many different conditions that they have, and they write about all sorts of things. So in our report, we do mention some of the direct quotes that women have commented on. And often it's not, as you say, it's not necessarily the heart disease or the cancer, but it's things like that they had an infection, or they had a sort of a gout or something like that, something that's a bit less sort of likely to come up in a survey question. But yes, certainly the women do write about it, and write about how this one particular woman, I can remember how her attack of whichever condition it was came when she was juggling, caring for her husband and also children, and just how difficult that was for her.
I will say there was also an other box where the women got to type in some of the other issues.
Yeah, that's right. Yeah. So women could type in other conditions that they had. Yeah, certainly. Okay, and just another question. I just wonder whether there are any survey questions asking about the quality of childcare and any gender role attitudes. That's from Ning. No, we didn't ask about that, so I can't really comment on that. Thank you. Yeah.
That's all of the questions. So, oh no, we've got one last question come in.
Yep. Okay, so this is a comment from Danielle. Do you have any ideas or recommendations on policies that can be improved or put into place to help and support young mothers who struggle with childcare and their work-life balance? So I think that's a really important question. Thank you, Danielle. And the whole reason that we do these reports is to help the government inform policy. So I think one of the important things that we can do is to give the government absolute numbers and to break down and try to put some context around the numbers so that they can use those in terms of trying to formulate policies. Certainly having flexibility and having policies that try to encourage not only flexible workplaces in terms of encouraging employers to provide flexible options where possible for caregivers, as well as flexible options for childcare. I think that is certainly what a lot of the women are sort of, in terms of some of the comments, are sort of asking for. So certainly that is part of it. I think the other important thing is to think about, it's not just a single woman, it's often a dyad or a triad, it's the whole family, and it's often not one type of child care or help in replace of another, but it's them all working together. So in terms of exploring options where childcare can be provided more flexibly, perhaps at places of employment and that sort of thing as well. Yep.
Okay. Thank you very much, everybody, again, for sharing your lunch hour with us for the launch of our major report. So I've messaged out Leigh's email address, and I'll just get it to, again, it is l.tooth, T-O-O-T-H, @uq.edu.au if you have any specific questions, and we'll make sure that you all have the link to download the report afterwards. And thank you again very much for joining us.